Everyone can see my screen?
Yes.
Thank you. So I'm going to take you through a talk on decision-taking in glaucoma surgery. One of the most difficult decisions, as many of us would agree, is that of recommending trabeculectomy. This is largely so because of the uncertainties involved. Can we do without surgery at this time? Can we change the medication? Is this a one-off elevated intraocular pressure? Am I sure that there has been progression? Is my patient non-compliant? Will the surgery be successful? Will there be a wipeout of the remaining central field of vision? Will reducing the intraocular pressure prevent further deterioration? Is there some other cause of glaucoma progression? Will the patient benefit at all? Will his personal life improve? Will his professional life improve? What is the cost of glaucoma surgery to him? Will there be any complications? So glaucoma surgery may be indicated as a primary procedure. It may be secondary following primary failure, or it may be associated with cataract surgery. It may be a tube you are thinking about, or it may be MIGS. We will consider some of these situations to give a view to the trials and tribulations of the mind while making a decision for glaucoma surgery. So here we have the same disc, the same patient, different features, and different management. So with an intraocular pressure of 18 millimeters of mercury, supposing, let's say he's on 2 medications, we would say, let's just wait, let's not do anything. With an intraocular pressure of 21 millimeters of mercury and still 2 medications, we would say, let's add a 3rd medication. With an intraocular pressure of 24 millimeters of mercury and on 3 medications, we would then consider surgery. So this is a 43-year-old female and with the best corrected visual acuity of 6/6. You can see that the intraocular pressure was about 19 in the right eye and 17 in the left eye on beta blockers. The right eye shows a significant notch superiorly and a large cup. And you can see that there is significant retinal nerve fiber layer loss also. So what do we do with a patient like this? For the time being, we are just watching. We're looking for progression. And if there is any progression, then I think that we would perhaps either increase the number of drops or we may consider something else. But for the time being, we just watch actually. This is a 68-year-old with the best corrected visual acuity of 6/9 in both eyes. The preoperative intraocular pressure was about 21 millimeters of mercury. And at that time, he was not on any medication. After putting him on beta blockers and prostaglandins, the intraocular pressure reduced to 16 and 18 millimeters of mercury. He was pseudophakic to start with. And we then took a decision that we would do trabeculectomy in both eyes, considering that we were a little unhappy with compliance and other things. And you can see that the retinal nerve fiber layer is really short, except for the fact that the macular retinal nerve fiber layer is still not as thin and has really not bottomed out actually. So the post-operative intraocular pressure was well controlled. And so we were fortunate that the trabeculectomy worked and perhaps we may have made a right decision actually. This is a patient who came to us and she had very thin sclera and it was very hard to make a decision actually because she had very poor vision in both eyes and she had staphyloма that you can see in the photograph of her eyes. And superiorly also, the sclera was very thin. And when we did take a decision after explaining everything, you can see the flap that I'm dissecting was extremely thin. And unfortunately, buttonholed when I put one of the, when I passed the needle to take a suture because it was so thin, just tore a little bit actually. And we could see the fluid coming out and we sensed that it's not going to work out if we had to leave the patient be. So we actually put a scleral flap on this area, a donor scleral flap on this area. And in spite of that, there was significant hypotony for the first week. And fortunately now the intraocular pressure has increased, but the bleb doesn't seem so good. So these are the travails of taking on surgery. Sometimes, you want to do the best, but sometimes you don't know actually. Let's take a couple of cases for primary angle closure glaucoma. So decision-making revolves around the presentation and the level of disc damage. pressure reduction, and as soon as you can, is an inescapable fact in PACG. This is achieved either by doing trabeculectomy alone, by combined lens and glaucoma surgery, or by lens surgery alone. The ability to predict what might serve the purpose adequately in a given patient is still open for discussion. However, one cannot go very wrong by choosing either of the above, except for the possible complications that are inherently associated with each of the options. So this was a 60-year-old male who was diabetic, hypertensive, presented with pain and diminution of vision in the right eye. The right eye had a vision of hand movements, and the left eye was 6/6. The right eye had chronic angle closure with 360 degrees synechia. The intraocular pressure was very high on 4 topical medications, and the lens thickness was high, and the antechamber depth was very shallow. And he underwent a combined surgery in the right eye, knowing that we are not looking for great visual outcomes, but that we wanted the intraocular pressure to be controlled so that his quality of life would increase significantly, and he might retain whatever little vision he had. And he underwent suture lysis and bleb needling, and the last follow-up at 6 months, the intraocular pressure was 18 millimeters of mercury on 2 topical anti-glaucoma medications. And you can see here the right eye, the disc is really short, and you can see that there is significant thinning of the retinal nerve fiber layer, and the infrared image shows macular changes, whereas the left eye disc and the retinal nerve fiber layer were healthy actually. This is the second patient, 51-year-old male, and the left eye intraocular pressure was 48 millimeters of mercury. He was having episodes of colored halos lasting for a few hours since the last 6 months. He had total synechial closure, and the lens thickness was 5.25, and the chamber was extremely shallow. He also underwent combined surgery, and on last follow-up on 2 anti-glaucoma medication, the intraocular pressure was 22 millimeters of mercury. And you can see that the left eye, I think we are going to be able to save the vision, and you can see the changes in the retinal nerve fiber are very interesting. There's retinoschisis, there's a sawtooth appearance that you're getting this patient, and this is something that happens because of acute episodes of rise in intraocular pressure. The retina just seems to give way because circulation gets blocked out very significantly, whereas the right eye is doing quite well actually. Let's go and take a look at some glaucoma implants actually. So the decision making in glaucoma implants varies from surgeon to surgeon. In general, if there is evidence that in a given clinical situation, trabeculectomy may not do too well, then it is important to consider the use of a glaucoma implant. This is a Cogan-Reese syndrome. This lady came to us with a vision of 6/18 with very high intraocular pressure of 52. The right eye angles were closed 360 degrees, and you can see the nodules in the right eye and the distorted pupil. And we did a primary Ahmed glaucoma valve implant, and you can take a look that she came back 4 days later with complete flattened anterior chamber, with the cornea touching the lens, and it was so scary actually. And this happened 3 times. We reformed the anterior chamber, and then within a day she would come back like this. And we opened up, and to our surprise, we found that there was excessive drainage in an Ahmed's glaucoma valve, something that I wasn't aware of before, because it's the only thing that the valve is not working well, and that's supposed to mean that the intraocular pressure might be very high. But this was a case where we could see the fluid gushing out actually from the valve, and so we actually we put a suture in the tube just like we do for the Adi valve, and we narrowed the lumen, and you can see in the bottom right hand corner, she's now doing extremely well, and the cornea has recovered almost completely. So there are times when you think you're making a great decision and you have a setback that makes you repeatedly then go back to the patient and try and do the best you can actually. This patient did very well because she came to us with uveitis. The uveitis was not responding the way that we wanted to, and the pressures were very, very high. She's very young. The right eye disc has already started giving way, and on maximal medical therapy, nothing was working actually. And so we decided to take her for a glaucoma implant, and she's done pretty well in the right eye. And so these are sometimes very difficult decisions, and you just keep on hoping that you made the right decision, actually. And I'd just like to bring this up just to, put into perspective that there's something called Translamina Cribrosa pressure differential. That's the difference between the intraocular pressure minus the cerebrospinal fluid pressure. We don't know how important it is, but it's considered to have a role to play that we don't completely fully understand, actually, but that it may be important in the development of glaucoma. That's what all the studies have shown so far, actually. And the challenge to us is that if you have a patient with an intraocular pressure of 18 millimeters of mercury, but the TLCPD is high, you may reduce the intraocular pressure to get a response, perhaps by even resorting to surgery after exhausting medical management. The second scenario is that if the intraocular pressure is only 18 millimeters of mercury, but let's say you knew the TLCPD, you could calculate it and it was normal, then the decision still needs to be made, but we may not be able to predict if reducing the intraocular pressure any further will help. So there are challenges when you take into consideration, you have a bird's eye view of the multiple factors that could be involved at different levels of intraocular pressure. Then I think decision making becomes a little challenging, and one needs to be a little thoughtful. Thank you all very much for this opportunity.